Hello everyone, Assalamu alaikum. I'm gonna talk today about the delta-delta ratio. If you haven't seen my video about the concept of the anion gap, I would advise you guys to watch it before you proceed with the delta-delta. In our plasma, electron neutrality is maintained. Cations are equal to anions. The main cation in the extracellular fluid is sodium. The main anions are chloride, bicarbonate, and other anions that we're not interested in counting them individually, but we consider them as unmeasured anions. We grouped them and gave them the name of the anion gap. The concentration is 12 milliequivalent per liter. Okay, now what would happen when you have an added acid into your body? We know that the hydrogen ions will lower the pH, causing acidemia. And in severe acidemia, there will be a dysfunction of the cells, including the brain and cardiac cells. That's why patients with severe acidemia may have acute confusion, may develop seizures, may have arrhythmias. So it is a serious problem, right? It's like a shock to our body. We have to absorb this shock. We have to buff this shock. What is the main extracellular buffer in our body? It is bicarbonate. Now, let's assume that we have 16 milliequivalent of protons. So 16 milliequivalent of bicarb will step forward and bind to the hydrogen ions, trying to neutralize the pH. That would form H2CO3, which will be converted by the effect of carbonic anhydrase enzyme into two things, H2O, the water, and the CO2. I have no problem dealing with water because 50 to 60% of my body is water. And I don't have any problem dealing with CO2 because I'm gonna exert it and ventilate it out by my lungs. All right. That's a great job from the bicarbonates side. Now, what would replace the bicarb? I have to maintain the electron neutrality, right? The anions of the acid, the anions that hydrogen has left behind will replace the bicarb. Okay. Do we measure these anions? No. So we'll consider them as unmeasured anions and we'll add them to the group of unmeasured anions, the anion gap. Okay. All right. If you see here, the anion gap has increased by 16 points, right? So the difference in the anion gap is 16 points up. The anion gap has increased from 12, the normal, to 28, okay? To 28. The difference is 16 points up, okay? The change, the difference is what we mean by the delta in math, okay? Now, how about the bicarb? Well, we lost 16 milliequivalent of bicarb. So the delta bicarb is 16. The difference is 16 points down. Okay. So it is a one-to-one ratio, right? But in an opposite direction. It's a reciprocal kind of relationship. The anion gap has increased up, the bicarb has decreased down by the same magnitude. Okay. I'll talk about that further. In this column, I want you to concentrate on the anion gap. In this column, I want you to concentrate on the bicarb. We have a patient with DKA. We lost 16 milliequivalent of bicarbonate replaced by unmeasured anions. The change in the anion gap is 16. How would you calculate it in real life? In real life, I will do the blood tests, right? And then I will calculate the anion gap. The anion gap will be sodium minus chloride plus bicarbonate, okay? It will be 28, all right? 28 minus 12, it will be 16. How about the bicarb? I lost 16, the delta bicarb is 16, all right? How would you calculate it in real life? You don't have this diagram in real life, right? So in real life, I will do the blood level of the bicarb, and it will be 8. It will be 8. So subtract 8 from 24, and that will be 16. So it is 1-to-1 ratio, and the result is 1. Okay. What does that indicate? It indicates that you're dealing with high anion gap metabolic acidosis, pure high anion gap metabolic acidosis, simple, not mixed high anion gap metabolic acidosis. All right. Now, what would happen if you have a superimposed diarrhea? Well, with diarrhea, I know that I'm going to lose some of the bicarb in the GI tract, right? Okay, how would you replace it? How would you compensate for that? You will compensate by reabsorbing more chloride from the kidney. Okay, will that change the anion gap? No, this has nothing to do with the anion gap. If the bicarb is down by 4 and chloride is up by 4 by the same magnitude, that will not change the anion gap. Okay, so the anion gap will stay as is, 16. How about the bicarb? We lost already 16 with DKA, and now we lost another 4 because of diarrhea. So the difference is 20 points down, right? The delta is 20. How do you calculate it in real life? In real life, you will check the plasma level of bicarb. It will be 4. So subtract 4 from 24, and the result will be 20. If you notice, the delta bicarb is actually higher than the delta anion gap. Okay? And that's why the ratio will be less than 1. 16 over 20, it's less than 1. What does that indicate? Why the delta bicarb is higher than the delta anion gap? Well, it indicates that we are dealing with another metabolic process that is keeping the bicarb lower than what I'm expecting. And it should be metabolic acidosis. It is normal anion gap metabolic acidosis, and the cause is diarrhea in this example. Can you give me another example? Yes, when you lose the bicarb from the proximal tubule, as we see in proximal RTA. Okay, I'll give you another scenario. The same DKA patients, anion gap is up by 16 points. The change in the anion gap is 16 points. The bicarb here, you lost 16, so the delta bicarb is 16. It's 1-to-1 ratio. Everyone is happy. Okay, now what would happen if you have a superimposed vomiting? Well, I know that I'm going to lose some of the chloride molecules with the vomitus, right? Let's say we lost 8 milliequivalent of chloride. How would you replace it? I'm going to absorb more bicarb from the gut, and I'm going to absorb more bicarb from the proximal tubule. Will that change the anion gap? No, the anion gap will stay as is. If the chloride is down by 8 and the bicarb is up by the same magnitude, that would not affect the anion gap. Great. So the anion gap will be 16 as is. The delta anion gap, I mean. Okay, how about the bicarb? The bicarb, we said we gained 8 points, right? After we lost 16 points. All right. So what is the delta bicarb here? The delta bicarb, you will do the blood level of the bicarb in the plasma. It is 16. Okay, 16 subtracted from 24, it will be 8. Okay. Can you just figure out again the delta bicarb from the diagram? Yes, sure. So we said we lost 16, right? And we gained 8. So lost 16 points and gained 8 points. So the net is losing 8 points. Okay, so that's why the delta bicarb here is 8. Okay, so as you see, the delta anion gap is higher than the delta bicarb. The delta bicarb is lower than the delta anion gap. And as a result, the ratio will be high. Okay, why I have high ratio, why I have lower delta bicarb compared with the delta anion gap? Well, it indicates actually that you have another metabolic process that is keeping the bicarb higher than what you expect. And in this case, it is metabolic alkalosis. You have concomitant metabolic alkalosis. Okay, why? Because of vomiting. Do you have any example of metabolic alkalosis that may get superimposed on top of high anion gap metabolic acidosis? Yes, when you use furosemide, for example, you will lose chloride in the kidney and you're going to reabsorb more bicarb. Can you give me another example of the high ratio? Yes. When your baseline bicarb is not 24. What? Yes, but the baseline, let's say it's 36. How come? Well, this patient is known to have muscular dystrophy. This patient is known to have COPD, i.e., he is a CO2 retainer, and that's why he will have a subsequent compensatory metabolic alkalosis. The baseline is high, so if he has a superimposed DKA, for example, the bicarb will drop, but not to the level where the ratio will be 1-to-1. The ratio will still be high when you do your calculations. Okay, let's summarize. We do the delta-delta ratio in the context of high anion gap metabolic acidosis in order to know whether I have a concomitant metabolic disorder or not. The ratio is expected to be 1 in pure, simple, not mixed high anion gap metabolic acidosis. The ratio is going to be less than 1 when you have a concomitant normal anion gap metabolic acidosis. The ratio will be more than 2 when you have a concurrent metabolic alkalosis. Think of the causes. When the ratio is between 1 and 2, you still may have actually a concomitant metabolic alkalosis, but also you may still have pure high anion gap metabolic acidosis due to lactic acid. I used to get this question: what is the point of doing delta-delta? It will not change the management. Actually, that is not accurate. The abnormal ratio will let you realize that we have a superimposed problem that is significant enough to change the acid-base status. So let's say high stoma output. When you do the delta-delta, you may consider increasing the fluid, changing the fluid, or maybe you may consider giving a medicine that would suppress the GI secretions, like pantoprazole, for example. Okay. Now, what we have done in this tutorial, we have explained the concept of the delta-delta. We discussed the main and the most important principles. We have learned how to do the calculation, and we now know how to formulate the differential diagnosis for mixed high anion gap metabolic acidosis. This is more than enough for the residents in internal medicine. Having said that, if you are interested, please keep some of the points in the back of your mind. Hydrogen ion is not buffered only in the extracellular fluid, but also get buffered in the intracellular fluid. Bicarb is not the only buffer in our body, as we assumed in this video. Anions of the acid may not replace the lost bicarb completely. There are other factors that may affect the 1-to-1 ratio, factors like anion's volume of distribution, factors like the rate of renal elimination and the GFR. I'm going to touch base on these points. I'm actually working on it in a new video. I hope I can finish it soon, inshallah. Thank you so much, guys, for listening. Please stay safe of COVID. Goodbye.